So I know you've been putting your questions in the chat box. Thank you for doing that. And Zara has been collating them. So let's move straight to the questions if we can then. We have Rachel and Anne here with us. We've also got Professor Lambert and Dr. Zara Hussain. She's been doing a great job collecting them for us. So if I just start off, I think that the first few questions obviously came during Anne's presentation. Anne, when is the ideal time to test if the patient can be tested too early, as you talked about?
Well, the NICE guideline advice obviously is that a patient, if it is asymptomatic, there is no indication to test. I would say that even if a patient became symptomatic within days of, ideally it's probably unlikely they'd be test positive before 2 weeks, but if a patient has symptoms, it may well be worth testing at that point, but you need to be aware that it might be negative. Of course, there's always a possibility that that was the tick they saw and they've had a tick bite several weeks previously or something as the cause of the symptoms. So the NICE guideline says test if patients are symptomatic. If they've had a test within 4 weeks of the bite, then wait another 4 weeks after that test and then do another test. But I think every time, on top of that, there's the issue that whenever you're doing the testing, you can go on and you can instigate treatment if you feel it's clinically indicated. I don't know if Dr. Lambert has any other suggestions on that.
You're on mute, Jack.
Okay, so I'm not in mute now. I've never, you may want to mute me, but the point is an antibody test is an antibody test. We have people with negative antibody tests who are infected, and we have people with positive antibody tests who were infected 10 years ago and are now 100% cured. So you have to, it's a clinical diagnosis, and the antibody test can be supportive, but you shouldn't be, you shouldn't be hanging your test. You shouldn't be hanging your diagnosis exclusively on an antibody test, which is imperfect.
Thank you. So, that's the sort of summary of it. It's helpful. It's helpful in the toolbox, but it's not the key thing. And if you've got supplementary questions to these, please do send them off in the chat box. Here's the next question. If the rash has improved, but it's still present to a lesser extent after 3 weeks antibiotic treatment, do you treat for longer, or do you accept that it's a resolving rash and reassure the patient?
If you're asking me, I would say I've heard two sides. I've heard from the American doctors who say if there's still a rash, keep treating. UK doctors have said don't give any more treatment, it's resolving. But again, I'd like to know what Dr. Lambert's opinion is on that.
Well, I can just give you an interesting anecdote. A GP from near Liverpool had a rash, had a bite, saw the tick, had symptoms, got the treatment, felt better, and then 2 years later, the rash came back again. And they actually biopsied the rash at a research facility in the Midlands at one of the universities, and it grew Borrelia. So there's, there can be persistent infection in the presence of a rash. So we don't have availability of PCR for Borrelia, but this particular case, even 2 years later, there was still, the rash came back again. And when they biopsied the rash, there was active replicating PCR proven Borrelia present. So, I would say that if there's still a rash present, and especially if there's still symptoms present, it kind of implies persistent infection. The guidelines say 3 weeks, but these are guidelines. Not everybody gets better in 3 weeks with other infections. So I think you need to use, like Osler says, you need to use clinical judgment. You need to listen to the patient.
Thank you for that. Thank you for that view. And here's a slightly related one. If a decision has been made to treat for Lyme disease based on rash or symptoms, and the patient returns 6 weeks later wanting a blood test to confirm if they had Lyme disease or not, is this a reasonable request? Rachel, would you like to start off with that one?
Sorry, Eileen, could you just repeat that question?
If a decision's been made to treat for Lyme disease based on the rash or symptoms, and the patient returns 6 weeks later wanting to have a blood test done to confirm whether they actually had Lyme disease or not, would that be a reasonable request? It's presumably a GP asking this question, and
Yeah.
ask this
No, I mean, based on sort of my experience and also the guidelines. I mean, if you had erythema migrans, you have Lyme disease, the test may well be negative anyway. Once you've had antibiotic treatment, it probably will attenuate any antibody response, so it's very unlikely it would come positive. If you have an erythema migrans, you have Lyme disease, and the NICE guidance state that, so there's no need to do a test at that point. I hope that answers the question.
Thank you for that. Dr. Lambert's nodding. And here's another question, I think, Anne, probably for you. Up until what stage are the antibiotics effective? It's quite a wide open question. Up until what stage are the antibiotics?
I think that's a problem. It's a question for Jack, really, because I think we're not able to define that.
Yeah, we don't know. I mean, the current guidelines only address early Lyme infection. You know, if you see a tick, if you start to develop symptoms, if you see a rash, you start to develop symptoms, you treat with 3 weeks of antibiotics. If you're continue to be unwell, you give another 3 weeks of antibiotics. But what if you don't have the rash? What if you don't remember the tick, but you're kind of environmentally exposed, and then all of a sudden, a year later, you start developing symptoms, and this happens, you know. There is no guidelines for the treatment of longer duration of Lyme disease. The only data there is data from the American literature of people with late Lyme arthritis. So these are people who don't develop symptoms or develop persistent symptoms late down the way. The 3 weeks of antibiotics don't work in that situation. Studies have shown that you need to treat for up to a year in studies with people with late Lyme arthritis. So these are people who had a tick bite, who didn't do anything about it. And then almost a year later, they just started developing symptoms of arthritis. And then they were proven to have Lyme arthritis. 3 weeks of antibiotics didn't work in that situation. But there is no guidelines. The current NICE guidelines only address early Lyme disease. And I think that is the tip of the iceberg. There's lots of people, for example, you know, Arlene's son, who didn't present till later. The guidelines are, there are no guidelines. So I just think better research, better understanding. We don't prescribe, you know, I have patients with lymphedema who get cellulitis. The guidelines say treat 10 days with antibiotics for cellulitis. The people with lymphedema, they don't have good clearance of infection. They sometimes take 4 to 8 weeks of antibiotics to clear. So I just think we have to like treat patients, not treat guidelines. So I think that's true for every other disease. But for some reason, for Lyme, it's, you know, some of my colleagues say, you've had your 2 weeks of antibiotics. If you're still sick, get over it. Well, you don't get over it. You don't get over a bacterial infection by telling people to use their willpower to resolve an infection. In some situations, you need longer courses of antibiotics.
Can I just say that if the question is there a point at which you've missed the boat? I don't think we can say that there is a point where it's too late. I personally treated somebody who had developed Lyme in childhood, been absolutely, definitely confirmed with multiple tick bites and definite IM rashes, but for some reason told you don't need any antibiotic treatment for this, it'll go away by itself. He remained ill till his late 20s and only came to the clinic under duress. He wasn't convinced, he wasn't sure anything would help him. As a trial of treatment, the tests were all negative. After a trial of treatment, after a month, he said, you know, I think I might be working out what it's like to be normal. I think I'm starting to get improved. And this wasn't placebo. He wasn't convinced. He only did it to keep his mum happy. Now, that wasn't the answer. That wasn't the fix. But after seeking further prolonged treatment, a year later, he went off traveling around the world. Now, he'd been very, very sick for a long time. So I think there are people who can respond. That may be a temporary and fluctuating response, but there are people who will respond a long way down the line.
Thank you very much, Anne. It just highlights these are real stories, and you know, there's nothing better, is there, than just hearing the reality of it. Here's one. Are there any tick bites that don't need antibiotic treatment? Who would like to take that?
I guess I'll be happy to do that. So, you know, when people get a tick bite, they've done studies in France. Ticks carry lots of different bacteria and viruses. There's tick-borne encephalitis. It's now actually in the UK. But the presumption is when you get a tick bite, Borrelia is the #1 bacteria that is the most transmissible. That's what we understand. So we don't have perfect diagnostics. We have to depend on our clinical, skills. So yes, there's tick-borne encephalitis now recognized in Devon, in the New Forest, and now in Norfolk. It's heading north. It'll be in Scotland soon, I imagine. But the point is if you get a tick bite and you get symptoms, you have to presume that Lyme disease is #1 pathogen, maybe other co-infections. So I would err on the side of treating because there's no better testing we have available. You have to use your clinical judgment.
That's a helpful statement for you all to take away, isn't it? That this is a clinical decision-making situation. Here's another one. Is antibiotic resistance a problem? Professor Lambert, I think this is for you as well.
It doesn't seem to be. This is, interestingly, bacteria that rapidly replicate, mutate. Lyme is a slow-growing bacteria. It has a slow-growing cycle of almost a month. So we can't do resistance testing because we can't grow the bacteria, but it's thought that resistance is a very rare phenomenon with Lyme disease. So the standard antibiotics, doxycycline, amoxicillin, appear to work in the early infection. Unfortunately, in the chronic infections where it's longer standing, you may not see a response, as quickly to the antibiotics, but that doesn't imply resistance. So we don't think there's significant resistance for Lyme disease to the standard antibiotics.
Thank you for that. And of course, this is a good time to just remind everyone to come back for the next 2 webinars because Dr. Lambert will be talking about treatment of the most difficult cases and the more complex cases and longer courses of antibiotics. So that will be the 22nd and the 29th of September. We'll do a similar session. What about this question? If a patient attends and does not think they removed all of the tick, would you give them antibiotics? Anne, what would you be thinking there?
I think this is something people worry about quite a lot. I think if the tick hasn't been fully removed, then by definition it's been a traumatic event. So there is potential that if the tick was infected, that infection has been passed on. But it's just as likely that the tick wasn't infected. We said earlier the infection rate within ticks is 0 to 16%. So I think in terms of Lyme disease, you would just treat as any other situation. There's a potential risk, but you need to watch and see. Having said that, if you've left a bit of a foreign body in the skin, you might end up with a bacterial infection. So that would be something else to watch out for. Try and remove it if you could, see if there's any reason to treat a bacterial infection. One of the things I didn't say earlier was that if you feel it's still a toss-up between whether someone might have a cellulitis or it might be an EMASH, it's likely that doxycycline may be effective in treating the cellulitis. So if you're really not sure either way, it would probably be worth doing that. I don't know if anyone thinks differently, but I think people worry a lot about tick heads being, the head of the tick being left in, but it's not a Lyme risk as much as a potential local infection risk.
A few nods there. So top tip on the use of doxycycline there. Here's an interesting one. Should all patients with a diagnosis of chronic fatigue with a possible exposure to tick bite, even if no clear history, should they be treated with antibiotics? Dr. Lambert.
I'm happy to answer that question. So look, I get asked to see lots of patients with chronic fatigue syndrome. And I decline to see most of the patients who have had chronic fatigue syndrome from the day they were born. But lots of people who are high functioning that all of a sudden get to be 42 years of old of age, and they all of a sudden get this acute illness that gives them chronic fatigue. And in that situation, you have to say, what precipitated that chronic fatigue? Chronic fatigue is not a diagnosis. It's a description of a set of symptoms. So, but what happens is they get put in the chronic fatigue basket. So I think we now have COVID that's causing chronic fatigue, but they don't have chronic fatigue syndrome. They have COVID-induced chronic fatigue syndrome. So I think we should have, it's a red flag. If somebody has sudden onset of chronic fatigue syndrome and other multi-system conditions, because usually Lyme affects not just the brain, it affects other systems as well. So in the setting of somebody with chronic fatigue, sudden onset of chronic fatigue or recent onset who are previously well, I think you should have a low threshold for thinking Lyme disease, even in the setting of a negative antibody test. So the important thing is history, and onset of disease and multi-system manifestations. And that's as good as it gets. We don't have better diagnostics. The antibody test is not perfect. So I think you should have a low threshold. If you think Lyme disease is a possibility, and I do this, I tell my patients that I screen, I said, look, I think there's Lyme disease, and I'm going to put you in a trial to see if you respond. If you don't respond, then I stop the antibiotics. But the only reason I'm starting you in the first place is because I, as a clinician, think that your chronic fatigue syndrome may be explained by Lyme disease. It's until we have better diagnostics, that's as good as it gets.
I would say within that, you were still within NICE guidelines. NICE guidelines says that if you have a clinical suspicion, you can treat. And I've personally seen patients who've had chronic fatigue for a long time respond to doxycycline. Now, that may not, again, be a permanent thing, but if you've given a trial of treatment and you've seen an improvement, that patient can decide where they would like to go to from then. As a GP, you can't continue treatment, but you may have at least given them the opportunity to see whether there's any effect. But you're within NICE guidelines.
Thank you. And there's just been a follow-up from that same questioner asking, would that trial be 3 weeks of doxycycline then?
I would probably use 6 because a GP could only use doxycycline. I would probably use 6.
Right.
Dr. Lambert would have a different.
Yeah, well, the thing is that we, if you give, unfortunately, if it's chronic and it's been going on for a longer period of time, is the treatment for chronic infection the same as acute infection? Use Q fever, which is another infection. If you catch it early, 6 weeks of doxycycline cures early Q fever. But if you don't diagnose it to a year, you actually treat with a combination of doxycycline and hydroxychloroquine for 18 months. That is the treatment for chronic, late diagnosed Q fever. We have no guidelines for Lyme disease. So unfortunately, until there are guidelines, I think you should really use your clinical judgment. We use doxycycline for treatment of acne for 6, 12, 18 months, It's a safe drug to use. We shouldn't be using it just willy-nilly for everybody with chronic fatigue syndrome. But if you suspect an infection, I think maybe you should go longer than 3 weeks, but you have to kind of assess clinical response. And I cut people off. I stop treatment all the time when my hypothesis that there's an underlying infection is wrong. So I think we need to use clinical judgment. This is what medicine is about. There's a certain art in medicine. It's not just about guidelines.
Mm-hmm. I'm just thinking of people feeling protected within the system. It's a start. You could have a trial and without feeling you'd broken any rules.
These are helpful comments and coming from medics who are treating patients and seeing patients. So I hope that's been helpful to you, the questioners for that particular section. Sorry, someone.
There was a question I've seen from somebody that came directly to me, and I think it's I'd like to read it out if that's okay. It is from Eleanor. And it says, I saw in an outdoor store today, which is Trespass, Lyme testing kits for sale where ticks can be sent off for analysis post-removal. I don't know if anybody knows anything at all about that. I'm not aware of anybody selling kits. I know that ticks can be sent off. They won't be tested at Public Health England. You can send them there for their tick surveillance. They won't be tested there. But I think Rachel knows a bit more about tick testing in the UK?
Yeah, I know that the NICE guidance doesn't recommend doing it, but I think certainly there can be a place for it. So in my little area where loads of people locally have had Lyme disease, if anybody gets a tick bite in my garden, I'd rather know. And of course, no test is 100%, so you'd never give it full credence. But for example, last summer we had 3 tick bites in the family. I sent 2 off, and they tested negative, and everybody was fine. The 3rd tick bite was me, and by the time I found it, I already had an erythema migrans, because I'd already had, I think my immunity was primed from my previous one, so I didn't need to send that one off. But that's about a 30% in that little tiny trial, 30% infection rate. I suspect it's about that locally. So I would always send them off from where I am. And there's a lab called BioBest up, I think, in the Borders that you can send it to. It's a vet lab, I think. So I've used them. And certainly a friend sent some ticks off that were attached to her small child. And of the 3, one of those came back positive. And we used that to argue for some prophylaxis, because it had been a traumatic removal. So there's not guidance, but where there's a really high risk and you don't just want to use prophylaxis blindly, I think it can be another tool in your armoury.